The third case is a 29-year-old male who was diagnosed with chronic face CML 9 years ago. With, as you can see, our patients come late in the course of their illness, so they have usually intermediate to high score SOCAL or ALTS. So at that time, he was given hydroxyurea initially, and then he was put on imatinib. He was in hematologic remission for 4 years. He lost his hematologic remission, maybe because of compliance, adherence issues, and he was on clinical grounds. Since we don't have mutation analysis studies and so on in our center, he was started on nilotinib 400 milligrams twice daily. He again achieved complete hematologic response until May 2022, and he was lost to follow-up, discontinued imatinib for more than 10 months. Nilotinib for more than 10 months. When he came back in March, he had multiple cervical, supraclavicular, and axillary lymph nodes, the largest measuring 3 by 2 centimeters. And the liver, spleen were palpable, particularly the spleen was very huge, 10 centimeters below costal margin. Lymph node final aspiration cytology showed immature lymphoid cells, lymphoblasts, accounting for almost 80% of the cells. So the diagnosis was considered to be extramedullary blast crisis because the high cell count in the periphery at this point was 170,000. Myeloblasts were only 9%, and the basophils were 6%. And then the BCR-ABL was 54%. This was on a gene expert. And at this time, the patient could do the tyrosine kinase domain mutation analysis, which showed 315 mutation. He has been on, we obtained ponatinib on a compassionate basis, and we put him initially on 45 milligrams, by the way. He could not tolerate it. So now he is between 15 and 30 milligrams on ponatinib. And the repeat BCR-ABL recently, as of November, was 34%. Then this was again on a gene expert. So the question is, in this patient with extramedullary blast crisis, what could be really the optimal treatment? Because we are limited here with the medications or stem cell transplantation. What advice could you give us to the treatment of this patient? Thank you.
Beppe, would you care to lead?
Yes. Can you hear me now?
Yes.
So I think that I was commenting this case before. This is a novel blast crisis, extramedullary. So in a young patients, so I think that it should, if possible, just to be treated at the moment with a lymphoid blast crisis regimen, chemotherapy, in order to achieve at least an hematological remission, and then to move to stem cell transplant, I would say, and then to continue after the transplant, the ponatinib that he is receiving in part, only in part, is responding at the dosage which can be 50 milligram per day or each other day if he is not able to maintain a good response and so on. But certainly this is a guy to be transplanted because he is so young, and of course is not so compliant to the therapy because but at the moment probably he is, and we need, however, to find a solution, a possibility of a real cure for him without losing time in trying different TKIs and so on.
Naeem?
Amha, can you hear me?
Yes, I can hear you. Thank you, Professor. So the question
I'm not
is what
professor,
I'm
I'm
worried
Beppe.
about.
Sorry, I'm not professor, with due respect to you.
Thank you. So he has both the 315 mutation and the crisis. So in
Yes.
developing countries like ours, these patients are really very, very difficult to treat. We get the ponatinib, as I have reported already, on a compassionate basis. He has the last, by the way, white cell count we have on this patient is 3,100 with an absolute neutrophil count of 980. His hemoglobin is 8.9. The platelets are 138,000. So he is on 15 milligrams on ponatinib now. So I was just wondering, is there any, live stem cell transplantation? Is there any other treatment modality that we can provide this patient in a center like ours?
Yeah, there is a possibility.
Beppe, the sound's
I
really
don't
gone
think
again,
that
Beppe.
these
Yes.
drugs are available in Ethiopia at the moment. So I think that chemotherapy is something which is, in spite of the fact that after chemotherapy, can you hear me?
Yes,
Can you hear
we can
me?
hear you now.
Okay, sorry, I'm coming and going because I'm in a difficult situation, environmental situation. So I was saying that there is the possibility to use specific antibodies in addition to ponatinib in this case, like blinatumomab and so on. But I don't think that these drugs are available in your country at the moment. So I think that probably the best thing is just to use chemotherapy, and chemotherapy is an induction therapy for any other kind of acute lymphoid leukemias. I do not know what you are using at the moment as chemotherapy, is your preferred chemotherapy for ALL. However, then just restart ponatinib at a dosage which is about 15 milligrams. Sometimes 15 milligrams is not after recovery, of course, of the white blood cell count and so on. 15 milligrams is not tolerated after, so well tolerated after stem cell transplant. So probably I would do it every other day, but I wouldn't stop in this case the TKI therapy even after the transplant. But the transplant is the best option to save his life, I think.
Naeem, what do you think?
Yeah, I agree completely with what Beppe has said, and I think he's 29 years old. I would take him to your ALL pediatric type protocol that you use for high-risk patients, along with TKI, and get him into remission, take him to transplant, and then post-transplant, as Beppe has said, to use maintenance therapy the way he can tolerate at that time. Fully agree.
Amha?
Yes, thank you. I understand. Given the limitations we have here, we are thinking maybe, if ponatinib is not really tolerated by the patient, I was thinking going back to dasatinib. Would it help in this group of patients? Because we cannot consider stem cell transplantation here. So playing among the TKIs, would dasatinib help in this situation because he has never received it?
But yes, I perfectly understand. So no, is not available the stem cell transplant. So in this case, we need, I would say, even because of the situation, a full dosage and not of dasatinib, in my opinion, because it's unlikely, but of ponatinib, because he's already on ponatinib and is responding in part, and is of course is not achieving the full dosage of ponatinib, which in this case should be 45 milligrams per day.
Professor, I made a mistake. I was thinking of not dasatinib, but omacetaxine. Because he has 315, he's not going.
Omacetaxine is not good. What you can use, and if you send me an email, I will send you the person to contact. is the new
Yes.
Chinese drug, which is called Olanrewaju also. But and the possibility, you don't have access, you told me before, to Eltrombopag, of course. Am I correct?
Yes, we don't have, yes.
So I think the only possibility is to have a full dosage of TKI. Maybe you can ask, we can ask, and if you send me an email, I can put you in contact with this Chinese company, which is providing for compassionate use of Gebremedhin, which is already registered in China. And I would say that in this case, maybe with some support, I would say. But the only possibility is to use a drug at the very, because Gebremedhin probably is less also thrombocytopenic, although we didn't test it so far. I will send you some new data that have been also reported attached this year. But however, in cases which were also unresponsive to Gebremedhin, have responded to. But I think that the chances to have a longer time response to this of these patients are quite reduced without the stem cell transplant. But we can speak about this. Then we will see if there is the possibility just to have the possibility to perform a stem cell transplant and so on here in Italy, and we will see. However, stem cell transplant is the best option for these patients, definitely, without experimenting too much, which at the end of the day is not cannot be conclusive for him, for his life. Young patients, so we need absolutely to do something for these young patients who have an entire life in front of them, and we have to save this life because now it's possible, so we have to do it.
I think Naeem is in furious agreement with that. So
I agree. Yeah, I think that should be fine.
Great. Okay. In that case, we will move on to Lanre's case number 3. But just before that, can I raise a question that's come on the chat from Professor Fatou Samba Ndaya from Senegal? She says, my question is about the management of patients with CML who present at the same moment autoimmunity disease. What kind of treatment do they need? What about the prognosis? Naeem and Beppe, would you care to comment?
I would say the disease was autoimmunity disease, autoimmunity.
Correct.
So I think that you can, of course, treat autoimmunity and also TKI therapy at the same moment. There is no, I would say, of course, we know that CML, in a certain sense, is a disease which is responsive to immunomodulators, but not in negative sense. So there is certainly a sort of self-defense against the pH positive clone of the body. So we are decreasing I would say, the immune system. Probably we are a little bit favoring, although this has not been totally demonstrated, that we can little favor the onset of pH positive clone. We do not know. This is a possibility. But I would treat the two separated diseases as two separate diseases in the same subject. So I wouldn't stop the TKI therapy, which in part have been also be considered immunosuppressive, in particular in Madre, and I would treat for the other disease with the appropriate drugs. Without we cannot. It depends of course also the severity of the autoimmune disease that we are facing. But I would consider both the situation, not in the same subject. So we have to take care of the possible interaction of the drugs and so on. But I wouldn't stop TKI therapy, for example, just to follow the autoimmunity problems, and I wouldn't stop the autoimmunity therapy just because of CML.
Naeem, do you have a quick comment? And then we'll move on to Lanre's case number 3.
Yeah, this is, I agree with this. I have actually 2 or 3 patients, and as Beppe said, they are being treated differently. So no issues with autoimmune should be treated separately with whatever the disease is recommended by the specialist, and the CML can be treated effectively with the tyrosine kinase inhibitor. There's no need to change unless there is a clear-cut correlation with some sort of development with that TK. Otherwise, they're completely well-tolerated treatments on both sides, on both diseases.